Thank you very much, Dr. Feketa, for that kind introduction. And I also would like to thank the College of Physicians of Philadelphia, the American Philosophical Society, and the Hospital of the University of Pennsylvania Department of Surgery for this invitation and for this wonderful honor. And I really must say, I'm very pleased to deliver this evening's lecture commemorating Dr. Rhoads, who, as you heard, is a pioneer who made such significant contributions to the medical field. So as you can see from this first slide, I'm going to be talking about lessons learned and challenges that we are now involved in facing with regard to the historic pandemic COVID-19. Let me start off with this first slide. I show it because literally within days of the realization that we were dealing with a brand new challenge with a new virus, I wrote a viewpoint in the Journal of the American Medical Association, and I entitled it Coronavirus Infections More Than Just the Common Cold. And I did that not to be facetious at all, but to call to the attention of the readers of the viewpoint that this new coronavirus that we were dealing with falls within a category of viruses that we've known about for a very long period of time. So this is the phylogenetic tree of the coronaviruses. The ones that have been known now to infect humans are in red font, but the yellow highlighted viruses are viruses that we've known now for decades and decades are responsible for the common cold that literally each and every one of us have repetitively been exposed to and infected with over our lifetime. Even though they haven't changed much, we seem to get reinfected by these. And that's the way the situation was for a long period of time. And then in 2002, we were challenged with the first pandemic coronavirus to our knowledge, and that is the severe acute respiratory syndrome. And then 10 years later, in 2012, another coronavirus, the Middle East respiratory syndrome, affected people at first in the Middle East, and then some spread not really very much, as in severe acute respiratory syndrome 1. So within a period of 10 to 12 years, we were faced with two coronaviruses that have pandemic potential. And here is with both of them fit on the phylogenetic tree of coronaviruses. They're both beta coronaviruses. And I'm going to get back to that in a moment when we talk about countermeasures against these viruses. But then let's get back to January 2020, when the first cases of an unusual pneumonia were noted in the central region of China, in the city of Wuhan. The Chinese identified this new strain of coronavirus as the source of this outbreak of pneumonia. And getting back to the phylogenetic tree, here is where that virus stands. As you can see, very closely related to certain bat and other coronaviruses, and within the same group of beta coronaviruses as SARS-CoV-1 and MERS. Within a couple of months, WHO declared COVID-19 a pandemic at a time when there were about 118,000 cases in 114 countries. And as we'll see in a moment, that has exploded in an extraordinary way. At that time in March, there were about 4,000 documented and recorded deaths from this new coronavirus. So now let's fast forward to where we are today in May of 2022. This is a map of the world showing the global COVID-19 pandemic and the number of COVID cases per 100,000 people over the last 7 days, with the darker blue being a large amount and the lighter blue being less so. As you can see from the yellow box on the lower left, we've now had over 500 million known infections with coronavirus SARS-CoV-2. And although the deaths are recorded at a bit over 6 million, it is estimated that that number is maybe 2 to 3-fold what that recorded number is. Here in the United States, unfortunately for us, we have been afflicted as severe or more severe than virtually any other country with few exceptions, with the total case count now being about 80 million. And we are right at the point of crossing the threshold of 1 million total deaths due to COVID-19. And again, that number is likely a bit of an undercount. It has been an extraordinary experience and journey over the last 2.5 years. This is the global picture of multiple variants leading to different surges going from March 2020 up until the present. Note on the right, the very large surge which we've experienced called Omicron, and I'll get back to that variant in a moment. That variant has multiple sublineages. It has peaked and is now coming down throughout the world, but we better be careful about getting too optimistic about that because we've had resurges before. So that's a bit of a thumbnail on the epidemiology. Let's take a look at the virology for a moment. As I mentioned, this is a beta coronavirus, the same subgenus as I showed you with the original SARS-CoV-1 and a number of bat coronaviruses, which unquestionably was the original source of this, likely through an intermediate host, because we know SARS-CoV-1 went from a bat to a civet cat to a human, and MERS went from a bat to a camel to a human. As I mentioned, it's an RNA virus with a large genome, about 30 kilobases. It has 4 structural proteins, the most important of which is the S protein, which is the spike, including its receptor binding domain shown in the green little squiggly in the spike protein on the right-hand side of the slide, which binds in the human to the ACE2 receptors, which are widely distributed in the upper and lower airway, hence infection through the respiratory route, as well as in the GI tract and in other tissues throughout the body. Now, as I mentioned, we have gone in this world, including in the United States, with a number of variants, and the one that we're currently dealing with is an Omicron variant. Why is that so problematic? We got hit badly with Delta, which spread very rapidly and bumped off the table, as it were, the other variants. But Omicron is even more transmissible than Delta. And the reason is, if you look at the spike protein of Delta on the left and Omicron on the right, the red circles are amino acid substitutions resulting from mutations. And as is plainly obvious on this slide, the number of mutations, including in the receptor binding domain of Omicron, is much, much more than that of Delta, leading to an evasion of immune response, whereby the immune response is associated with vaccination as well as with prior infection, were not as protective when it came to Omicron, leading to the widespread of infection. And in fact, another way of looking at family trees of SARS-CoV-2, look how far distance Omicron is from the other of the variants, way off on the side, which led to the reason that we had such an escape from the immune response generated by the other variants. There have now been, and this is what we're dealing with today, literally as I speak, with sublineages of Omicron referred to as BA1, BA2, and now most recently, the evolution of a BA2.1, 2.1, which again is a bit more transmissible than the other sublineages, but does not appear to be more severe. Thus, there has not been a concomitant increase in hospitalizations relative to the number of cases. So getting back to what I showed you a little bit ago, this is the evolution of different variants. And notice globally, there was the original wild type way over to the left of the slide, then an alpha, a beta, a delta that originated in India, and an Omicron that originated in Southern Africa. If you look at the United States, note the United States was not strict with the beta variant and only had the alpha, the delta, and now we are in the midst of an Omicron, which is way, way up and then came back down. But as we now know, if you've been following it, the cases are starting to creep up a bit. It went down as low as 15 to 20,000 a day. The count yesterday was between 80 and 100,000 cases on a given day. This is another way of looking over a period of several months of how one variant led to another, where first it was mostly alpha, beta, gamma. Delta came along and pushed it off the chart. And as I mentioned, Omicron now accounts for the overwhelming majority of the isolates throughout the world, including in the United States. And as I mentioned, within the Omicron, there are subgroups of that. And right now, as of yesterday, BA2 occupied about 56% of the isolates, and BA 2.12.1 about 42% of the isolates. Again, the reason this is important is that each of these escapes a bit more from immunity. Immunity against infection, but the protection against hospitalization and death still remains reasonably strong with the vaccines that we're using. All right, let's spend a few minutes on transmission. What do we know now, 2.5 years into the outbreak? Undoubtedly, this is a respiratory-borne virus. The transmission is by the inhalation of mucosal surfaces of respiratory droplets. But now we know for sure what we were not certain of early on, that it also spreads by aerosol, namely fine aerosol droplets that can remain in the air for a period of time and don't, because of the weight of the droplet, fall to the ground, which is the reason why we've seen in closed spaces such an easy spread. Now, these aerosols or droplets get deposited on the mucous membrane of the nose, the mouth, and the eye. We did think that there was transmission through contact with contaminated surfaces, but we know now that's a very rare event. So the idea of scrubbing things down in which there was someone who might have been exposed in a particular area, right now we realize is not really worth the effort put into that. The risk is greatest in enclosed spaces with poor ventilation, such as indoor places, as well as during behaviors such as exercise, which is the reason why gymnasiums are an increased risk, being indoor and where people are breathing heavily, as well as singing in choirs in churches, which is the reason why there have been outbreaks among choirs in different church functions. Now, I want to point out something that's a bit unusual and maybe in some respects unprecedented, that although the mortality of this in certain individuals, as we know, is profound, given that we've had about 1 million deaths in this country, at least 1/3 of people who get infected never develop any symptoms at all. Even more striking, that close to 60% of all the transmissions come from someone who's infected but has no symptoms. Either they never will develop symptoms, or they're in the pre-symptomatic stage, which is the reason why this virus so insidiously spreads. And we've seen that in situations where people gathered in an indoor setting, nobody had any symptoms, and it became a super spreader event. This is the reason why. Let's take a look at the clinical course. As I mentioned, for those who do develop symptoms, remember 1/3 don't, the presentation is very much like a flu-like syndrome, with the signs and symptoms shown on this slide here. There is one unique aspect of this, is the curious loss of taste or smell in a high percentage of people, at least with the Delta variant, less so with Omicron. And that loss of taste or smell can linger even after recovery from the acute stage of the outbreak. Now, for those who do get symptoms, about 80% of them are mild to moderate, whereas 15 to 20% are severe, requiring intervention, including mechanical ventilation. The case fatality rate for people with severe symptoms ranges from 2.3% to those who require mechanical ventilation, where it can be as high as 20%. But with our getting better at treating people and treatment for advanced disease, this fatality rate has gone down dramatically. So who's at risk for severe illness? Without a doubt, elderly individuals are at much greater risk for severe illness. And the older, the greater the risk, particularly individuals greater than 75 years of age. But in addition, people of any age with certain underlying medical conditions. And paramount among these are diabetes, hypertension, obesity, chronic lung disease, cardiovascular disease, and other systemic diseases. Children are not exempt from serious disease. There's a misperception. For sure, it is less likely for a child to develop a severe outcome than it is with an adult. But as to the last count, there have been close to 13 million cases in children, over 120,000 hospitalizations, over 1,500 deaths, and more than 8,000 children have experienced the multi-system inflammatory syndrome, which can be really quite severe, leading to hospitalization and in some cases, death. Now, there are post-COVID-19 conditions that can be looked at into two major buckets. One is explainable by residual organ system dysfunction that is associated with original organ system damage. So if a person gets severe pneumonias requiring ventilatory assistance, it would not be surprising that they have lingering of pulmonary function abnormalities for some time after recovery. However, there's another more puzzling group who have signs and symptoms not completely explainable by readily apparent pathogenic processes. And that is referred to as long COVID. And that involves anywhere from 5 to 30% of individuals who, following so-called recovery from COVID, have the lingering of symptoms shown on this slide, characterized predominantly by severe fatigue, usually following exercise that would not normally have caused fatigue in an individual, some of whom have been well-conditioned athletes, as well as things like palpitations that are unexplained, tachycardia, myalgias, paresthesias, sleep disorders, and something referred to as brain fog, or the inability to focus or concentrate for considerable periods of time. The medical management of SARS-CoV-2 is threefold: control of symptoms that might not require even consultation with a physician, namely staying at home, taking anti-inflammatories. Then there's the advanced disease that requires end organ support and hospitalization. The most common requirement is ventilatory assistance by putting a person requiring mechanical ventilation. And then there's antivirals and immunomodulators. Although there's overlap in this, targeting the virus, and I'll get to some of the drugs that are used in a minute, the earlier the better in the course of disease. Whereas advanced disease, where you have aberrant inflammatory and immunological response, might require moderating that host response, which can be a bit out of control. And here are some examples of how that's done. One can target the virus with a number of drugs that are either FDA approved or have been given emergency use authorization. Another is to moderate the host response by dampening an aberrant inflammatory response. One can do that with commonly used drugs like dexamethasone or monoclonal antibodies that are directed against various components of the inflammatory response, such as tocilizumab or baricitinib. Now, I schematically put this in what I call a toolkit for non-hospitalized patients to prevent them from requiring hospitalizations. And the drug that's most commonly used and referred to now is the protease inhibitor Paxlovid, which gives you an 89 to 90% diminution in the likelihood that you require hospitalization. There's also remdesivir, molnupiravir, and a monoclonal antibody called bebtelovimab. And all of these now are available by either full approval or emergency use authorization to prevent people from requiring hospitalization. Let me move on now to vaccines, which really is the major success story of this historic outbreak. And in fact, Science magazine in December of 2020 deemed the development and the implementation of vaccines for COVID as the scientific breakthrough of the year. And the reason for that is that because of decades of investment in biomedical research, we were able to go from the first week in January, when the sequence was developed in the sense of made public, to the time we went into a phase 1 trial 65 days later, to an extraordinary 11 months later, to have a vaccine, more than one, that was shown to be highly effective to the tune of 94 to 95%, quite safe, and was going into the arms of individuals. There are now in the United States 3 platforms. One you're very familiar with, the mRNA by Moderna and Pfizer BioNTech, but also to a lesser extent, an adenovirus vector, which is the J&J, and others that are recombinant proteins with adjuvants, which are in the process of requesting an emergency use authorization. These vaccines have been spectacularly successful in the sense of when they first became available in December of 2020 to a couple of months ago. It is estimated that it has saved in the United States more than 2.2 million deaths, more than 17 million hospitalizations, and has saved close to $1 trillion in healthcare costs. That's the good news. The sobering news is that we need to do better because we only have 66% of the population is fully vaccinated. 71% of people 5 years of age and older, and we're waiting on approval of the vaccines for people from 6 months up to 5 years. We've done better with the elderly. About 91% are fully vaccinated, and about 95% have received at least one dose. Globally, we must do better, because if you look at low-income countries, particularly in sub-Saharan Africa, the percent of the population, as you can see here, is about 15.9%, whereas in the upper and middle-income countries, the percent of people vaccinated are much, much higher. So we have a responsibility as a developed nation to make sure with our resources that the lower income countries not only have vaccines, but the infrastructure to be able to get vaccines into the arms of people as vaccinations. Now, you've all heard of the need for booster shots. Why do we talk about the need for booster shots? The reason is that there is waning immunity. The immunity wanes for two reasons. One, even with natural infection, immunity against coronavirus wanes after a period of time. Remember, I told you several slides ago that we keep getting reinfected with the common cold coronavirus. These are, on the left-hand part of the slide, looking at the waning immunity of the Pfizer, the Moderna, and the Janssen. This is what happens when you look at the effect of giving someone a booster dose. Look at the rate of hospitalization per 100,000 of unvaccinated people in red, 145. If you're vaccinated and you don't have a boost yet, it goes down to 35. If you're fully vaccinated and you get a booster shot, namely a third shot of an mRNA, the hospitalization rate goes way down to 9.8. The same holds true for deaths. If you look at unvaccinated and the death rate per 100,000 is 12 for unvaccinated, 1.8 for vaccinated with no boost, and a very low 0.45 if you're boosted. Now, the question that's right up front for everyone is, will we need a fourth COVID-19 shot? Well, we have very good data from other countries in addition to our own data. So let's look at where we are right now when you get a booster that's restored by a second boost. The first booster doses, that third shot, restores the waning immunity and the effectiveness of a primary vaccination, including against severe disease. However, even the effectiveness of a first booster dose wanes somewhat over time. And there's growing evidence that a second vaccine booster can actually restore the effectiveness for certain populations. And I'll give you some examples from that. We have very good data from Israel because they have been ahead of us in the situation of boosting. So in a study of more than 1 million people who are elderly, 60 years of age, an additional booster vaccine 4 months after the first booster, namely after the third shot, resulted in a 3.5-fold lower rate of severe illness, and that protection lasted for 6 months. In another study from Israel, in over 365,000 people, the effectiveness of a fourth vaccine, when you compare it to the third dose, was 61% against symptomatic disease, 72% against hospitalization, and 76% against death. And another way of looking at this, if you look at the mortality of people who've gotten the first dose boost in the blue compared to the people who got the second in the tan, there's no doubt that that fourth dose, particularly in elderly individual, makes a substantial difference. So based on that fact, the FDA, as well as the CDC, the FDA authorized and the CDC recommended the eligibility of a fourth dose boost for individuals 50 years of age or older, particularly more elderly people, and particularly those with underlying conditions. So let's take a look now at the future. Where are we now? What do we need to do? It's probably clear to you from what I was saying about the need for intermittent boosts that we need a universal coronavirus vaccine. And I wrote about that in December of 2021 in the New England Journal of Medicine. Because in the past 20 years, we've had 3 coronavirus disease outbreaks: SARS, MERS, COVID-19. Why do we think we're not going to have another one sometime in the future? And in addition, within SARS-CoV-2, we've had multiple variants that I've already described to you in prior slides. So we need innovative approaches to induce broad and durable protection against coronaviruses that we know about and those that we might be challenged with in the future. So let's get back to what I showed you earlier in the talk. This is the phylogenetic tree. If you look at a pan SARS-CoV-2 vaccine, forget about a pan coronavirus, that's quite aspirational. We would want a vaccine that would cover all of the variants that we know and those that we don't know. The next step would be to get a vaccine that covers what we call the subechovirus subgroup of this, shown here, which would be SARS-CoV-2, CoV-1, as well as many of the bat coronaviruses that are always a threat to us. Now, how are we doing that? We're using different platforms, nanoparticles that have different spike proteins of a number of variants, giving you a diverse antibody response. Another important challenge is to protect against infection and spread. And the way to do that would be developing a vaccine that could be delivered through intranasal mist. Because if you block the acquisition, you will block also transmission. So the vaccines that we have now are very good against systemic disease, but as you know, they don't do that well against protection against infection, which is the reason we're seeing so many people, even though they're vaccinated, getting infected. But thank goodness, if you're vaccinated and boosted, like I've shown you on several slides, you're protected against severe disease. So we at NIH now are in the process of looking at what the best of the dose and the best of the variant would be as we get into the fall and winter months of 2022. And we've already began evaluating what that second booster shot will be. In addition, we have a very big antiviral program to develop even better antiviral drugs modeled against what we did with HIV, where we looked at the replication cycle shown here. That big blue circle is a cell. The virus is in the smaller circle, and very similar to what we did with HIV and hepatitis C is to identify vulnerable components of that replication cycle and to target antiviral drugs. All right, what's the end game for 2022 and beyond? What can we hope for? I think it's easy to explain by looking at this in multiple different phases. The pandemic phase is where we are right now. We have gone from the fulminant pandemic phase, where months ago we were having 900,000 cases, tens of thousands of hospitalizations, and 3,000 deaths per day. We've decelerated now to a much lower level. We hope to stay there. What can we really hope for? Well, do you think we'll eradicate this virus? I have to give you the answer that's quite honest as no. And the reason is we've only eradicated one human virus in history, and that's smallpox. And the reason we were able to do that, because it's a phenotypically stable virus. Smallpox doesn't have variants that change. Number two, the vaccine and infection-induced immunity is lifelong, and we've had a widely acceptable global vaccination campaign. So we eradicated smallpox. Question is, do you think we'll eliminate SARS-CoV-2? I think the answer is no. And the reason is because we eliminated polio in this country, we've eliminated measles. By elimination, we mean it's no longer present in your country, even though you haven't eradicated it from the world. And the reason we were able to do that with measles, again, measles is a phenotypically stable virus. The measles that we had 30 years ago is same as the measles that we have right now. In addition, similar to smallpox, the durability of vaccine and infection-induced immunity is essentially lifelong. And in addition, we have a widely accepted national vaccination campaign against measles and polio. So what about SARS-CoV-2? Well, unfortunately, it's different. I've already showed you on multiple slides that we have the evolution of genotypically and phenotypically diverse variants. So we're not dealing with a stable virus. In addition, both vaccine and infection-induced immunity wanes. I showed you several slides of that. And unfortunately, given the anti-vax situation now, we don't have a widely acceptable, effective vaccination program. There's too many people who just don't want to get vaccinated. For that reason, I don't think we're going to eliminate this virus. What do I think we can do? And I believe we should strive for it, is what I refer to as control, but control at a level that is low enough that it doesn't disrupt the social order the way the last 2 years, as we've seen done. Effects on the economy, on our ability to socially interact, on our schools, on our employment. How do we do that? Control is given different names. It could be a return to normalcy. Some refer to it endemicity. Some say it should be similar to what we do and accept every year. For example, with respiratory syncytial virus, the common cold coronaviruses, or influenza. I believe that we can do it. We have to implement common sense respiratory hygiene, attention to ventilation, voluntary masking where appropriate. I don't think we need, we will have to be wearing masks all the time. Very unlikely. It may require intermittent vaccination, and we want to make available antivirals and monoclonal antibodies. In other words, a level of virus that hasn't disappeared, but that we can feel, particularly those who are vaccinated and boosted, that we can go about our lives without a substantial disruption of what we do. That is an eminently attainable goal if we do the things that I'm talking about. I want to close with this last slide. It's a paper that I wrote with my colleagues 14 years ago in the Lancet Infectious Disease. And what it really says very clearly is that emerging infectious diseases have been with us forever, even before recorded history. They have been with us currently, and they be with us as we go on in the future. So I refer to it as a perpetual challenge. In order to meet a perpetual challenge, we need to be perpetually prepared. So let us hope that the lessons that we've learned from this pandemic will be put to good use as we prepare adequately for the inevitability of another pandemic. May not be in our lifetime, but for sure we will be challenged with another outbreak.